Very good morning, everyone. Welcome again to ISG Masterclass Series 2 and happy Raksha Bandhan to everyone. So with this, last week we had a case discussion on chronic diarrhea, and that was of small bowel type. And this was a wonderful discussion and learning experience for all of us. I'll give you feedback of that patient. This patient was diagnosed to have a common variable immune deficiency, and he was given IV immunoglobulin. To his symptom responded. This patient is under follow-up, and in subsequent classes or master classes, we'll let you know what really happened later to this individual over 12 weeks till we are connected with each other. Now coming again with one more new case, talking about again small and large intestine, and again diarrhea and pain abdomen. So again for this we have a wonderful panel for this. We have three residents from PGI Chandigarh. I'll request Dr. Usha to introduce them. But before that, let me introduce Dr. Usha Datta. She's a professor and head of gastroenterology at PGI Chandigarh. She will be one of the panelists. And along with her, we have Dr. Anurag Jaina, who will facilitate this whole session. We also have Dr. Jayanti, V. Jayanti, one of the great teachers of our country. And she loved teaching, and we all admire her so much for her passion for teaching. She's from Chennai. Then we have Dr. Matthew Philip. Matthew Philip is again one of the key member of one of the key gastroenterologists in our country, and he's from Kochi, and very good interventionist, and he's always there in all the workshops which we have on endoscopy. And we have Dr. Devendra Desai from Hinduja, Mumbai, again, one of the great gastroenterologists, IBD expert. His area is mainly IBD, and he will join on this panel. Maybe with this, I introduce to you, maybe ask the Usha to introduce the residents from PGI. Unmute yourself, please.
Thank you, Dr. Govind. Good morning to everybody, and welcome to all the panelists for today's meeting, and happy Raksha Bandhan to all of you. Today we have Dr. Anurag Jaina. He is our post-DM senior resident. He is with us in the department, and he'll be facilitating the case discussion today. And I have Dr. Jayendra. Can you show the mic, the thing to Dr. Jayendra, Dr. Naveen, and Dr. Daya. Dr. Jayendra, can you introduce yourself? Just by raising your hand. Dr. Jayendra, then Dr. Naveen, and Dr. Daya. They are senior residents who are going to be exam going this December. So we would have a case discussion being presented from a patient who's right now admitted in our department. This patient was admitted about a week back. And we will share the case discussion with all of you. Dr. Jayendra will present the history of the patient. Dr. Naveen will handle the examination finding and the discussion related to that. And Dr. Daya will handle the differential diagnosis related to this case. Dr. Jayendra, please, we'll start sharing the case with all of you.
Dr. Usha, please, we'll have a, before that, we'll have a basic introduction.
Okay.
Right.
Yeah, Dr. Govind, go ahead.
Devendra, can you allow, Dinesh, can you allow sharing your slides, please?
Oh, sorry, yeah.
Dinesh, can you share a slide, please?
Sir can share a slide. Just share a screen, sir.
I cannot. I cannot do that, please.
Sir, try once again, sir. Govind sir, you can try, you can share. Sir.
No, I cannot because there's a pop-up window which shows who can share, and I don't have a sharing option.
For the audience today, we would also have 10 questions for a quick poll from all of you. So stay logged on, and then you'll get 10 seconds to complete your poll. So stay within that 10-second time. These are simple questions which have been designed in and around the case and on basic knowledge which any gastroenterology resident should have. So please stay tuned in.
Sir, can you try, sir? Can you try, Govind, sir? Just share your screen. Govind, sir, you're disconnected. Hello.
Dinesh, can I share screen or?
Yes, sir, you can share screen, sir. Your audio has got very fade.
Dinesh, I cannot share screen, so I'll allow Usna Kusa to go on.
Okay. Okay, and maybe in between I'll bring in, just after we discuss the case, then we can have Dr. Govind take a short approach to such kind of patients. So we have an interesting patient here. I will now request Dr. Jayendra to present the case briefly. Dr. Jayendra, please.
We have Mr. GC here, who is a 30-year-old male coming from Ludhiana. He is an MBA professional. He is married for 1 year. He was admitted on 15th of August. He has presented with the fever, which was in the initial disease process, first 2 months, after 6 months back. And he had cough with expectoration also at that time associated with fever. He had vomiting for last 8 months. Weight loss for last 6 months, pain in central abdomen for last 6 months, and loose stools for last 3 months. Patient was in his usual state of health for 8 months back when he developed the fever, which was for 2 months at the beginning of the illness. It was documented up to 102 degrees Fahrenheit. It was intermittent fever associated with evening rise and night sweats. It was not associated with chills and rigor, and it responded to local antipyretics available. He also had cough with expectoration in the initial 2 months of the illness. With minimal expectoration, it was mucoid, not blood stained, not associated with chest pain or shortness of breath. The patient developed vomiting 8 months back, which was insidious in onset, non-progressive. He is having vomiting for last 8 months. It was intermittent, once or twice a week, mostly postprandial, most of the time after more than 45 minutes after meals. It was bilious. It had partially digested food particles, 250 to 300 ml. It was associated with nausea and mild upper abdominal distension. It was not associated with constipation, obstipation. It improved with the changing of to liquids, that only for last 3 months. Abdominal pain was there for last 6 months. It was insidious in onset, non-progressive, intermittent. Periumbilical, not radiating to any place. It was colicky in type, moderate in intensity, and aggravated by food intake. It was also associated with upper abdominal distension, not associated with constipation or obstipation, resolved after an episode of vomiting most of the time, and improved with liquid diet, which was started 3 months back. There was one episode of severe abdominal pain and abdominal distension in May, for which he was admitted at a local facility. A CT scan was done, and it was managed with RT placement. Patient is also having loose stools for last 3 months. It was 3 to 4 per day, consistency Bristol 7. It was yellow in color, large volume. Nocturnal episodes were present, 1 to 2 every day. It was associated with the borborygmi, flatulence, and foul smell. The patient did not have any increase in stools with the specific food intake. There was no urgency or tenesmus. Stools were not blood stained. There were no black stools. There were no greasy stools either. The patient had a significant weight loss over last 8 months. That was 35 kgs. He had a significant loss of appetite also, which was almost 75% from baseline. And he had swelling of lower limbs also. There was no history of lump abdomen. There was no history of perineal discharge, no history of arthralgia, no history of oral ulcer, rash or nodules. There was no history of palpitation or flushing. There was no history of night blindness, bone pain, easy bruisability or ataxia. There's no history of oral genital ulcers or hyperpigmentation. There was no history of TB or TB contact, no history of type 2 diabetes mellitus, thyroid disorder, no history of abdominal surgery. There's a history of fracture in the right arm due to sport injury in 2018. Personal history, the patient had a high risk sexual behavior. He is a non-smoker, non-alcoholic. He did not have any history of IV drug abuse. Dietary history, patient used to take 2,400 kilocalories and 100 grams of protein up to around 4 months of the initial disease process, and before that also. For last 3 months, the patient is having only liquid diet, which is around 100 kilocalories per day. Family history, patient is a single child born to a non-consanguineous marriage, and he is married. All of his family members are healthy. There is no history of TB in the family, and the socioeconomic status upper middle class. Treatment history, in the initial stage of the disease in January, an ultrasound assessment was done, and it was told that there was fluid in his abdomen. In May, a repeat consultation was done due to worsening of the symptoms, and a CT scan was done. Mantoux test was done. The patient alleged that Mantoux test was done. It was positive. And in May, on the 13th of May, ATT was started, and pain and appetite improved after that, but there was no response to diarrhea. On May 22nd, an episode of sudden onset severe pain abdomen happened, which with no history of constipation. He was admitted to a private hospital, was told to have a low blood pressure, which improved with conservative management. On July 16th, patient is saying that on the left side of the chest, a tube was placed because there was fluid in the chest. And on 25th of July, he had a hypoglycemic episode for which the patient was admitted and was told that the sugars were low. In the last 1 month, the patient has been transfused with 2 PRBCs. So this is the timeline of the patient. The patient has lost almost 35 kgs in the last 8 months. In the initial 2 months of the disease, the patient had cough and fever. And the vomiting has been there for the last 8 months, though it has improved a bit after starting the liquid diet since May. The patient is having pain abdomen since March, and it is continuous most of the time postprandial. It is associated with pain also. In January, the patient underwent ultrasound when ascites was documented. He has been on liquid diet since May. A CT scan was done in May also, and the ATT was started. RT was placed in the late days of May, and the patient underwent ICD insertion in July.
We will start the first poll question before the discussions. What is the type of diarrhea in this patient? Small bowel type, large bowel type, mixed or inconclusive? Patient has a very long history, so the type of diarrhea is crucial for the management.
Can we move on?
So the majority have voted, almost 55% have voted as small bowel type, 15% are still voting large bowel, 24% they say there can be a mixed component to it, while 6% are still inconclusive after the history.
Can we have the previous slide, please? Okay, Jayendra, you can hear me? Jayendra, you can hear me?
Can you discuss the history component of this patient? We will have 15 minutes total for discussion of the history. And there are 3 students here. You could raise issues with them.
Jayendra?
Any one of the 3 can answer.
You can hear me?
Yes, we can hear you.
Okay, Jayendra, actually, if you take the chronological sequence of events, the whole problem is actually 8 months when the vomiting, weight loss, and loss of appetite has started. No? So it's always nice to give a date, you know, like supposing, I think January you said is already ultrasound ascites. So I think the disease has started in the month of December or November. Onset, I think, is with vomiting, and there is weight loss and loss of appetite. And then the cough and fever has come on subsequently, if I understand right, that is 6 months.
Yes, ma'am.
Yeah. So can you just discuss and give a good summary of the entire case, because there are too many problems in this patient, one after the other. So you can just give a good summary.
Go ahead with the summary.
So, ma'am, there is a 30-year-old male patient with a disk duration of total 8 months, and he has presented with small bowel type of inflammatory diarrhea with features suggestive of malabsorption and features suggestive of partial bowel obstruction with malnutrition and anemia. Has a history of blood transfusions with a history of ATT for last 4 months. There's a history of left-sided ICD placement, a positive MAN2 test, presence of ascites, and there was one hypoglycemic and hypotensive episode.
And high-risk behavior. Okay.
High-risk sexual behavior, yes.
Yeah, that you think it's important?
Yes.
Yeah, so and with history of ICD placement. So all these are very important for this patient. So what do you think? Do you think this patient's got high gut obstruction, or he's got a gastric outlet obstruction? The initial history looked as it was a gastric outlet obstruction. Then he went to the patient had a peri-umbilical pain. So what do you think you're dealing with? You're dealing with multiple sites of obstruction, or you think it is only a partial small bowel obstruction? And how would you consider the perspective?
Ma'am, it seems like it is a partial small bowel obstruction. The patient never had frank abdominal pain or abdominal distension just after eating. Used to happen. Vomiting used to happen after almost 45 minutes to 1 hour. And there was only one episode of severe pain abdomen and abdominal distension for which he was admitted, and it was managed with RT placement. At that time, he had frank obstruction, but that also got relieved. So the patient is having seems like patient is having partial small bowel obstruction, ma'am.
The thing is partial small bowel, but your initial history was more like a gastric stasis, no? Except that the volume was 300 to 400 ml.
Yes,
so what are the various nutritional deficiencies you expect in this patient which you have not highlighted?
Ma'am, the patient was having bilious vomiting. So the obstruction was after
my question is, what are the various nutritional deficiencies you expect in this patient?
If the vomiting is severe, then the patient may have dehydration. That is mostly seen in high small bowel obstructions. In the lower small bowel obstructions,
Doctor,
patient may have features.
1 minute. I'm asking you, this patient has got long-standing diarrhea. He's got features of malabsorption. What are the nutritional deficiencies you expect in this patient, which has not been highlighted?
Ma'am, calorie deficiencies are there. There can be water-soluble vitamin deficiencies, fat-soluble vitamin deficiencies.
So can you just describe what in the history you get so that you know that patient has got the small bowel diarrhea resulting in nutritional deficiency?
Ma'am, the patient is having a severe weight loss. There is a weight loss of 35 kgs. So the patient is having, and there was with the stools, there was borborygmy, there was excess gas formation. The patient was.
1 minute. What are the things that you'll ask? You'll ask for glossitis, you'll ask for cheilitis, you'll ask for edema of the leg, you'll ask for very burning sensation in the feet. So you want to know whether there is an associated nutritional deficiency, because if it's partial small bowel obstruction, which I believe is more somewhere around the DJ or its proximal jejunal. That's the way the history is going, because it's not a large volume vomiting. But at the same time, patient has got features of malabsorption. So how's the appetite in this patient?
Appetite has decreased in this patient. It is almost 75% decrease from the baseline.
Okay, so the nutritional deficiency is a very important component. I think in a patient with long-standing history of 8 months, you must ask for history of edema leg. You must ask for any joint pain, ask for any history of fatigue, asthenia, breathlessness on exertion. He's an MBA. So what is his performance scale?
Performance status is not good, ma'am. It is 2. ECOG status 2.
So he's not going to work. He's bedridden. I mean, he's almost
bedridden, ma'am. Yes, ma'am.
He's bedridden. Okay, now you can give your differentials based on what is your history. So see that you ask these particularly important questions. Okay.
Yeah. So what are your differentials based on the history?
Ma'am, differentials based on history. The patient had diarrhea, obstruction, vomiting.
Now, give your differentials, doctor. Don't keep discussing
ma'am, my first differential in this patient would be intestinal tuberculosis, abdominal tuberculosis. both intestinal and peritoneal also. The second differential can be Crohn's disease, and third differential can be GI lymphoma.
Can you expand on that? Abdominal tuberculosis and intestinal tuberculosis, what is it that you want to cover?
Ma'am, the patient has a history of ascites, also has a history of positive Mantoux test. There are features of obstruction. So the involvement of intestines is also there. The involvement of peritoneum seems to be also there.
But patient is already on ATT for four months or so.
Months, and ma'am, only he has partially responded. Diarrhea has not responded. The appetite has responded a bit. The patient is not gaining weight, still having diarrhea.
So you would still consider tuberculosis as your first differential in this patient?
Yes, ma'am, still, because the patient is severely malnourished. The
So
ATT may not be helping the patient much.
So for me, it is like if a patient has anemia, hyperproteinemia, and a pain that is suggestive of partial small bowel obstruction, Crohn's ileitis would probably come as a first differential. There is a high-risk behavior. So if you consider the possibility of other coexisting infections that have creeped up in this patient, which is responsible for the malabsorption. Intestinal tuberculosis, if you want to consider in a patient who's got immune deficiency state, then ulcerative forms of intestinal pathology has been described. So you can get ulcerative types of lesions, and this can present as malabsorption-like syndrome. Okay.
Yes, ma'am.
And the lymphoma, in absence of the cough and fever that you're considering this patient, I think you have to mention whether it was COVID positive, COVID negative, especially with the COVID pandemic around. But you consider that possibility, whether it is feasible or not, whether the person does have that or not. Okay. And the need for transfusion. The very fact that he's required transfusion suggests that the lesion is ulcerated. There is periumbilical pain. There's not much of a history of hyperproteinemia, but usually patients lose weight and loss of appetite is usually because of the obstructing stricturizing lesion. Age also fits in. So to me, the first differential should be a Crohn's. And if you consider tuberculosis, would you consider this tuberculosis as a condition where it is responsive to treatment, or you think it's a non-responder? It's a non-responder to tuberculosis because pleural effusion is also coming subsequently.
So what Dr. Jayanti wants to highlight here is that in this patient, there is evidence of small bowel obstruction. There is evidence of inflammatory diarrhea affecting primarily the small bowel with features of malabsorption, and there is a partial gut obstruction. In this setting, the patient has severely malnourished. So she would like to actually have what she wanted to know from this whole thing is that postgraduates should focus on what are the other components of specific nutritional deficiencies you expect for different part of the gut, and specifically ask those components in the history. And the possibility in this patient is of a partially treated tuberculosis, which is not yet responding to therapy. Maybe there's underlying immunodeficiency. There was a history of high-risk sexual behavior. So whether there's a possibility of TB, which is either complicated, or TB, which is resistant, or TB with HIV. So since TB will be the first possibility because of response to therapy in the form of fever and anorexia improved with anti-tubercular drugs. So if we still want to keep tuberculosis, it is not just a plain forward, straightforward tuberculosis. It has to be TB with an underlying immunodeficiency, TB with HIV, TB with a complication which has not been handled, because this particular patient had an episode of abdominal pain, severe abdominal pain requiring hospitalization, and was told to have a sealed perf. So it could be a partially treated kind of a situation, a local complication which should have been surgically handled, did not get handled. Maybe there could be an internal fistulization. So something beyond just a routine common garden variety tuberculosis has to be considered. And obviously in a close differential, we have Crohn's and we have lymphoma. And as Dr. Jayanti was trying to say, that there was less symptoms to suggest lymphoma compared to Crohn's. So TB and Crohn's remain our first two key possibilities.
I agree. Yeah. And go on to examination, then we can again.
Okay, so we go on to examination. So the syndromic diagnosis in this patient is chronic, painful, small bowel type of diarrhea with a partial bowel obstruction with malabsorption, severe malnutrition, anemia, ascites, and a left-sided pleural effusion based on the history. So with this, we move forward. We have a question here which Dr. Anurag will pose for the poll. We have also a poll before this. Okay. So So we go on to
are there features of malabsorption? As we've all discussed, are there features of malabsorption in this patient? And Dr. Jayendra, could you please say what are the features of malabsorption in this patient?
In this patient, there is severe weight loss. There is diarrhea, which is having flatulence, borborygmi, which shows there is a carbohydrate malabsorption. The patient is having
Dr.
fetal edema.
Jayendra, I just give a clue, classify it as macro and micronutrient, and then say which are the macronutrient deficiency, which is the micronutrient, and which are the trace and the trace elements.
Yes, ma'am. The patient is having macronutrient deficiencies like carbohydrate deficiency, because the patient had diarrhea, which has flatulence, borborygmi. The patient is losing weight. The patient had fetal edema. The patient that means the patient is having protein loss also. In the later on examinations, we can find that the features of fat
malabsorption. On examination,
There
doctor,
was
one minute, we're still in the syndromic, so that's why I said
in history for fat malabsorption, ma'am.
Yeah, that's only macro. So for the vitamin deficiencies, you should have some questions. So just we already discussed this. Okay, so mention of the macro and the micronutrient deficiency.
The patient is having iron deficiency. The patient was transfused PRBCs. Though there were no features suggestive of fat-soluble vitamin deficiencies, there was no eyesight problem, there was no bony pain, there was no ataxia, there was no easy bruisability.
There is history of injury. Fracture.
Okay. So there is definite features of malabsorption in this patient. With this, we move on to the next question. Go to question number 3. Yeah.
What could be the best possible diagnosis based on history for this patient? This is the third poll question. As we discussed from the history, it's tuberculosis or Crohn's, less likely lymphoma.
Okay. End poll.
So the diagnosis of tuberculosis was based on what? Up to the history taking? After the history taking, what are the points to say he's got tuberculosis?
Ma'am, the patient in the initial disease process had fever. There was
he had an X-ray chest documenting the findings that he's got tuberculosis.
Ma'am, earlier there was Mantoux test was also done. There was
Only
a chest X-ray was done.
So chest X-ray, did it show tuberculosis?
Yes, ma'am.
So that's important.
Effusion was there. Effusion was there, ma'am.
No. It was proven tuberculosis, an MBA. So we would know that whether he's had a proven tuberculosis lesion, both in the lung as well as in the chest.
Just to clarify, the patient had fever, cough, expectoration. Chest X-ray showed lesions in the lung. We do not have that baseline chest X-ray, but the present X-ray shows evidence of cavity. So and a Mantoux positive at that time with history of response to anti-tubercular agent in the form of improvement of appetite, some weight gain initially, and then after that weight has been steadily going down. And also the patient had the fever responded and the respiratory symptoms transiently responded. So that were the features in this patient to suggest tuberculosis over Crohn's disease.
Right. Okay.
Okay.
All this should be brought out in the history. Okay.
The next poll question. All these are features that are common both to tuberculosis and Crohn's, except one of them. Pain abdomen, ascites, partial bowel obstruction, and weight loss. Could you please run the poll? This patient had all the 4 symptoms: pain abdomen with history of ascites, partial bowel obstruction, and weight loss.
So it is interesting to see that the audience has picked up correctly that ascites is not a common feature in a patient with Crohn's disease. Ascites can be seen in tuberculosis due to various reasons, either hypoproteinemia or due to peritoneal involvement or due to perforation peritonitis. You can have ascites. You can have ascites due to congestive cardiac failure. And there are various mechanisms of ascites in patients with tuberculosis. Also, granulomatous, extensive granulomatous involvement of the liver can have high SAG ascites. But the commonest cause of ascites in tuberculosis remains peritoneal involvement. Whereas in Crohn's disease, with a complication like a perforation, you can get ascites, but there the history will be completely different. And amongst these 4 features, pain abdomen, partial gut obstruction, weight loss are 3 features which Crohn's and tuberculosis share, but presence of ascites is one of the clinical features which tends to go against a diagnosis of Crohn's disease. We move on to the... Okay, so in this patient, the features which favor tuberculosis are ascites, lung involvement, especially a cavitatory lung involvement, presence of fever at the onset of illness, and improvement in ascites and appetite and fever after starting ATT. So these were the features would favor a diagnosis of tuberculosis over Crohn's disease. So, and also a MON2 positive at the onset. If MON2 was completely negative, it could indicate an immunodeficiency state or a malnutrition associated immunodeficiency situation or a Crohn's disease. However, this patient has not improved in a way usually patients of tuberculosis improve on ATT. There hasn't been a robust response, and that is why we discussed that there could be a resistant tuberculosis, there could be tuberculosis with underlying immunodeficiency states, either combined variable immunodeficiency or associated HIV disease because there was a history of high-risk sexual behavior. So given those kind of situations or a local complication due to tuberculosis like fistulization. So, Dr. Naveen, can you tell us what are the mechanisms of diarrhea in tuberculosis?
The mechanisms of diarrhea in tuberculosis would be there would be a proximal stasis of the gut contents proximal to the stricture site. It may lead to a bacterial overgrowth, and the ulceration in the small bowel due to tuberculosis may decrease the absorptive area for the absorption. That may lead to another diarrhea, and the lymphatic obstruction due to tuberculosis also leads to diarrhea, and the intestinal fistulation, which can bypass the part of the bowel, also leads to increased stool volume and may present as diarrhea.
Yeah, so this is a very important thing for all the postgraduates, that there are multiple mechanisms of diarrhea in tuberculosis. There could also be bile salt malabsorption because the distal small bowel is not functional. So we need to remember that if there is an obstruction, there can be secondary bacterial overgrowth and diarrhea. Ulcerations will lead to an inflammatory form of diarrhea in these patients, and altered motility due to involvement could be of the gut involvement and the mesenteric plexuses, as well as because of the adhesions in the bowel, there could be an altered motility. Lymphatic obstruction with lymphangiectasia can cause protein loss as well as can cause diarrhea, and you can have internal fistulization, which will result in rapid movement of content from one part of the bowel to the other with associated bacterial overgrowth as well as bile salt malabsorption. So Naveen, can you tell us what are the features in this patient favoring Crohn's disease? What are against Crohn's disease?
Patient had presented with a pain abdomen with features of a partial bowel obstruction, and also had a inflammatory diarrhea. These are the features that favor the Crohn's disease in these patients. Okay. However, the feature that doesn't favor the Crohn's disease are the presence of ascites in the initial part of the illness and the fever, and also had a lung involvement.
Yeah, so when this is a message to all the postgraduates that whenever you have differential diagnosis, place the single best possibility on the top, the others below that. And for each of them, you should write out what are the features which are in favor of a disease versus against the disease. So this helps you in arguing out your case. So now we come to the next poll question. Dr. Jaina, please.
What percentage of Crohn's disease patient respond to ATT at 2 months? What percentage do have symptomatic response?
Yeah, we'll end the poll here.
The poll results showed almost 57% told that the second option, that is 28%, respond to ATT at 2 months, and this is the correct answer. Normally, the patients of Crohn's disease, they can have global symptomatic response in 28% patients at 2 months. It can go up to 30%. The endoscopic response, however, is at a very lower side.
So there can be a transient clinical response in 28% of patients.
At 2 months, whereas at 3 months, the response is around up to 38% in patients of Crohn's disease also. However, at endoscopic response, we found that this paper found that the endoscopic response was only 5% in patients who had responded to ATT. Coming to the next poll questions, all are the pulmonary manifestations of IBD except. The options are organizing pneumonia, ILD, pulmonary infiltrates eosinophilia, and cavity. Our patient had a cavity on one of the X-rays. So uh, 87% said cavity is not a feature of IBD, and it is the right answer. Which of the following features is not an early feature of immunoproliferative small intestinal disorder? As one of our differentials was lymphoma in this patient. The options are fever, ascites, diarrhea, and weight loss. Almost 86% voted for ascites. Ascites is rarely seen in patients with IPSID. It can be very late manifestation as a presenting feature. It can never be a presenting feature in IPSID.
So the reason for keeping these poll questions for the residents is to understand that out of the symptomatology the patient presents to us with, certain features are strongly in favor, certain features are strongly against, certain features are weakly in favor, certain features are weakly against. So these are the 4 things we have to have in our mind for every disease pattern to know how to argue out your case. So certain features which are strongly in favor, if they are present, it makes your diagnosis more likely. If it is just a weakly present feature, you should not put too much of emphasis in your arguing out. Similarly, if it is strongly against, like presence of ascites in a patient with early IPSID, that would be not a very common feature unless there is hypoproteinemia causing ascites. So in that situation, you can have ascites, but usually patients with immunoproliferative small intestinal disease will have diarrhea, colicky abdominal pain, significant weight loss and loss of appetite, may have fever in about 50%, and ascites would be a very late manifestation. Whereas in this particular patient, ascites was an early manifestation. And again, features against IPSID are lung involvement, response to antitubercular therapy, and a partial gut obstruction. Do we move forward? Okay. With this, we move on history. We just want to discuss some components quickly. When do we suspect intestinal obstruction? Any patient who has recurrent vomiting. When there is recurrent vomiting and it is of bilious nature, large volume, you would suspect that there is a possibility of obstruction. Along with that, abdominal pain signifies that there is obstruction. Usually when you have a combination of repeated vomiting, abdominal pain, distension, obstipation, and constipation, these are the 5 cardinal symptoms of intestinal obstruction, of which obstipation is the most important. But obstipation will be present in complete intestinal obstruction. In partial intestinal obstruction, you may not have obstipation. So presence of obstipation tells you that there was a definite episode of intestinal obstruction. Obstipation, constipation, distension, and pain and vomiting. So always you should explore these symptoms and their interrelationship and assess it as an episode. And then see whether how long the episode lasted, was there a need for nasogastric tube placement, and how much was the distension. Conditions of intestinal obstruction without much of distension are proximal gut obstruction, like a duodenal obstruction, you will not have much of distension. Whereas an abdominal distension will also be absent in situations where there's a cocoon kind of a plastered abdomen, where you have recurrent obstruction and vomiting, but the abdomen may not distend because all the bowel loops are tied down to the abdomen. So in these 2 situations, distension may not be so prominent. In colonic obstruction, distension will be far more prominent because the whole small bowel gets distended. And on examination, the rectum would be empty and there are tinkling sounds and rushes on auscultation. So here you can see a distended abdomen in a patient who has had a surgery in the past. So adhesive intestinal obstruction is the possibility. And you can see all the small bowel loops all dilated. So you have to have an X-ray erect and supine in these patients. So as I said, how to suspect intestinal obstruction. And partial versus complete obstruction. Partial, the patient continues to pass flatus and there is residual chorionic gas beyond the transition point on an X-ray. It is common in conditions with adhesions and abdominal cocoon. And 60 to 80% will resolve with non-operative management. Whereas complete obstruction is, the hallmark is obstipation. There's no residual gas on the X-ray beyond the transition point. And small bowel barium meal follow through can differentiate early obstruction from high grade partial obstruction, and almost all need surgical treatment. Nowadays, we don't use so much of barium studies. We use CT enterography to define our level of obstruction and the nature of obstruction. So quickly, from the level of obstruction, it can be proximal small bowel, distal small bowel, or colonic. Let us start with colonic. Colonic, the pain will be in the lower abdomen. Vomiting is a late feature. Distension is a prominent feature. And there would be some change in the bowel habits just prior to the development of frank obstruction in most patients, unless there is a volvulus or a sudden cause of obstruction. Whereas in distal small bowel, here we consider, say, ileal obstruction, the pain will be periumbilical, colicky. Distension will be prominent because the jejunal loops will all be dilated. Patient may, at the initial point of start of abdominal pain, may still pass 1 or 2 stools and may pass some flatus, and after that go into complete obstipation because the residual material in the colon will get evacuated at the initial onset of the abdominal pain. Clinically, visible peristalsis can be fairly prominent in these patients and can be elicited by tapping the abdominal wall for eliciting this peristalsis. And in proximal small bowel obstruction, say classically a jejunal obstruction, there will be postprandial pain, copious bilious vomiting, because here in the duodenum, there is about 9 liters of fluid which comes in every day. So the largest volume of vomitus will be in proximal small bowel obstruction. And abdominal distension may be limited or localized, and there will be rapid dehydration because, as I said, 9 liters of fluid comes into the duodenum. And this is a classical abdominal X-ray of a dilated small bowel, and you can see multiple air fluid levels. Okay, so with this, we ask Dr. Naveen to discuss the physical examination findings. Dr. Philip Matthew, please take on from here.
Yeah. Naveen, carry on.
We had this patient who was conscious, who cooperated, and he was oriented time, place, and person. His vitals were, he had a blood pressure of 96/60 millimeters of mercury, and his pulse rate was 90 per minute, and his respiratory rate was 20 per minute, and he was affable, temperature of 98 degrees Fahrenheit, and his room air saturation was normal. And he was severely malnourished. His weight was around only 36 kgs with BMI of 11.5 kg per meter square. And he had pallor and bilateral pitting pedal edema, but there were no icterus, cyanosis, clubbing, or lymphadenopathy in this patient. And on head-to-toe examination and oral cavity, there was no thrush. Tonsils were normal, and there was no cheilitis or any oral ulcerations or hyperpigmentation of the oral mucosa. The skin was dry, scaly, and there was circular pink to red ecchymotic patches on the chest and upper abdomen at the site of ECG electrodes. And on the chest in the left side, the ICD site scar was also seen. And there was patchy loss, thin patchy loss of air was present on the scalp. And he had a center line placed on the left side. There was a Rayleigh's tube in situ and Foley's catheter in situ. And this was the image that was taken after the consent from the patient. Here we can see the patient is severely malnourished. All the muscle mass has gone, and the chest is thin, and there is a bony prominence of chest can be easily seen. And there are the ecchymotic patches at the site of the ECG electrodes. And there is also tattooing on the left forearm on the lateral side. And we can also see a site of ICD on the left side of the chest. And the patient was also malnourished. There was also loss of all the muscles of the forearm, and there also hollowing between the two forearm bones can also be seen. And in this image, you can also see in the ICD site scar and also ecchymotic patches and the prominent ribs and intercostal indrawing. And if hands, there was no clubbing on the hand, and there were white nails, which was a result of hypoalbuminemia. And coming on the abdominal examination, on inspection, the abdomen was scaphoid, and there was a visible lump around the periumbilical area, and all the quadrants of the abdomen was moving equally with respiration, but there were no sinuses or scars, and his hernial orifices were normal. On examination, on palpation, around this, on palpating this bulge out on the periumbilical area, it was ill-defined, and the bowel loops, small bowel loops were felt at the site of this periumbilical area. However, on palpation, there were no organomegaly, and in percussion, there was no free fluid. On auscultation, there were increased bowel sounds. And here, on parectal examination, the external inner sphincter tone was decreased, and the stools were stained with, fingers were stained with stools, and the proctoscopy was normal, and the sectional genitalia was also normal.
Okay, Naveen. It's a very interesting case, and we have a case here with a GI manifestation as well as a lung involvement and significant weight loss and anorexia, and over a period of 8 months. And started with some respiratory symptoms, then continuously he had vomiting, abdominal pain, and then later he had fever and respiratory symptoms worsened. So in general examination, you are told this patient is emaciated and he has got cachectic. And how do you assess the nutrition of a patient by physical examination? what all things you should say. We know that we have got major nutrition deficiency like carbohydrate, protein, and fat, and then followed by vitamin deficiencies and all. So you need to examine and tell all those things. So can you just highlight a little more on the nutrition status of this patient?
For assessing the nutrition of the patient, first we will measure the weight and calculate the BMI of the patient. BMI tells about the global nutrition of the patient. Then coming to the macronutrient deficiency, sir, in case of protein deficiency, patient may have white nails, suggestive of hypovolemia, although this can be seen in patient with failure also. And patient may have signs of protein loss like pedal edema, and the hairs may be thin, and there will be like graying of hairs and corkscrew pattern of hairs can be seen in patient with protein malabsorption. And in patients who had a deficiency of fat, the skin will be dry, scaly skin will be there, and the patient with fat malabsorption may also have a signs of neuropathy.
Okay. And also you have told that the patient has got pedal edema. So what could be the causes of what all things you should think in that? We know that it is because of pedal edema is because in this patient we think it is because of hyperproteinemia naturally. Because we are considering Crohn's disease also. Do you consider any other reason for pedal edema? Usually, suppose the patient has only one-sided pedal edema. What would you consider in a patient with IBD?
A patient is sick and is chronically bedridden. The one-sided pedal edema, first thing I would like to look for is any signs of deep vein thrombosis in this patient.
I think, in a patient with IBD, when there is edema, if it is unilateral, you should think about deep vein thrombosis. Even if it is bilateral, sometimes, IVC obstruction or obstruction thrombus section in both iliac regions can occur. And so you should be very careful about that. And you have told that the patient has got, skin examination, you have told there is some skin lesions. In skin examination of a patient with diarrhea, what all things you should examine?
Sir, about the skin examination of skin in a patient with diarrhea, first I will look for the signs of macronutrient deficiency. In that fatty acid deficiency, we already talked about the scaly skin, dry skin. In case of micronutrient deficiency with vitamin A, patient also have a increased disc formation and dry scaly skin. And also, you should also look for signs of vasculitis. You also look for signs for vasculitis, and also signs for in case of vitamin C deficiency, patient may have perifollicular hemorrhages. Yes. And easy bruisability and purpura and ecchymosis, which suggest the signs of vitamin K deficiency in this patient.
Yes, very good, very good. And this patient also, you told there is a skin lesion.
Signs of, and also the signs of IBD can also.
Yes, of course. You told about. I'm coming to it. Whenever you tell about chronic diarrhea and we are suspecting this patient, our second possibility is an IBD. So you should also mention about the skin manifestations. Should keep in mind all those things. And you mentioned about the oral cavity, and you told it is normal. What all are important negative findings in this patient? Because we know that this patient has probably tuberculosis, not responding adequately, and this patient could be having an underlying immunodeficiency, and so your oral examination is quite important in this patient. And you have mentioned that there is no thrush. I think it's very important. Also in IBD, we have to tell about the oral lesions which we see in IBD. What are the oral lesions we see in IBD?
Sir, the commonly lesions seen in IBD are the aphthous ulceration.
Okay.
Aphthous ulceration and
biostomatitis.
This is the patient may have a swelling of the lips or gingiva, where the patient may have cutaneous granulomas deposits over the areas.
Biostomatitis vegans can occur. No, there are oral manifestations of IBD. You should remember about that also. And this patient, you told there is a skin lesion, which you told it is an ecchymosis. What it could be? It's only an ecchymosis, and what could be the reason for that? Is it because of the easy bruisability of the ECG leads?
Actually, it was these spots were present at the site of the ECG electrodes. So these ecchymosis may be due to a patient is having malabsorption. It may be due to a low platelet count causing easy bruisability, or it may be due to a weak subepithelium collagen tissue where it might have gave away and leading to an ecchymotic patches. And also in the vitamin K deficiency can be suspected by this pattern?
We have a patient who has got a intestinal as well as a lung involvement. So can you think about other diseases which can actually produce skin lesions as well? So what are the possibilities of a patient who has got an intestinal involvement plus a lung involvement? We have discussed about tuberculosis. We have discovered because we know that IBD does not involve commonly the lung. If at all it is there, usually when a lesion comes like this, it could be because of an associated complication which can occur in IBD. So what are the diseases which can bring in? One is
lung and bowel involvement. One is the systematic vasculitis. Can have both lung and bowel involvement. Sir.
Different types of vasculitis, EGPA, anything can produce. Any other?
And such patient with cystic fibrosis may have both.
Chronic granulomatous disease, which is more common in children, can also present in adults. Chronic granulomatous disease, which can manifest both in intestine as well as in. And in that cases, you can get skin lesions, which can look like this type of darker lesions, which can be discoid. Lupus also can occur in these patients in chronic granulomatous disease. And in general examination, you have mentioned there is no leukodystrophy, agreed. And you did not mention about thyroid. Is there any relevance in mentioning about thyroid in a patient presenting with diarrhea, chronic diarrhea?
Sir, hyperthyroidism maybe.
You are not audible.
Thyroiditis causing hyperthyroidism may present with a chronic diarrhea. So in these patients have a swelling of thyroids.
Any other hyperthyroidism? I agree. No, they have increased frequency and it may mimic like a chronic diarrhea. Any other? Endocrine tumors of thyroid, no?
Medullary carcinoma of thyroid
can actually present with the diarrhea. They can have diarrhea as well. And I think now these are the things which we should do in general examination. I think is very important. And you have mentioned about tattoo and how relevant is tattoo in this case?
Sir, patient had a tattoo that after examination, I just asked the history retrospectively. He had the tattoo in his local space. It didn't get his tattoo at the standard treatment. This tattooing may point towards that patient may have an underlying exposure to a viral infection, so mainly hepatitis C or hepatitis B or an immunodeficiency virus infection.
And on physical examination, on coming to abdomen, you have told this patient has got a central distension. No? That's what you mentioned. What is in your mind? What do you want to convey to us? Distension is actually periumbilical. And what do you think it is?
Sir, that periumbilical distension, it was slightly prominent, and on palpation, I could feel a bowel loop, sir. Maybe a clumped small bowel loops, suggesting patient have a. You can see this type of feature in a patient having adhesions or a cocoon. The clumped up bowel loops can be seen in an area.
And on inspection, no, you can actually tell us what is the site of bowel obstruction, because in this patient we have got diarrhea along with an obstructive feature also. So the obstructive feature, the site of obstruction can be detected by looking at the abdomen as well as by sometimes by palpating. And if it is a proximal obstruction, you may not see anything except because the bowels may not be seen. If it is a distal small bowel obstruction, you can see small bowels there. If it is a colonic obstruction, you get a diffuse distension of the abdomen. You see all the bowel loops, isn't it? Here actually probably this is a distal small bowel obstruction. And you mentioned about rectal examination. What all things you should tell when you do a rectal examination in a patient with a chronic diarrhea? Because in inspection also you have to say that what all things you should say.
Sir, on a rectal examination, first you will inspect the perirectal area for any excoriations or any ulcerations, or in case of a skin tags and perineal fistula or sinuses. We should look for an actual examination.
That is very important. We are actually considering IBD as a second diagnosis in this patient. So always say about the patient, whether the patient has got a perineal lesions like fistula, swelling, perineal tags, and excoriations, perineal disease, etc. needs to be taught. And on examination also, you should always, we are suspecting intestinal obstruction. So you should always tell whether the rectum is loaded or rectum is actually empty. Suppose the rectum is loaded, we need to rule out spurious diarrhea in these patients. No? Am I right? We should always mention whether the rectum is empty or not. Because rectum is empty, then there is an obstruction above that level, isn't it?
Patient may have a overflow diarrhea.
Okay, and other thing is, I just want to bring into your notice. I think the physical examination wonderful. I just want to bring in was the here we have got a combination, and there is a history of patient with hypoglycemia. So I don't know how you correlate hypoglycemia in this patient.
Patient is severely malnourished. One, the hypoglycemia due to multifactorial in this patient, and it may be due to one is the decreased intake. He was in the home. He was only on liquid diet. The calories may not be adequate for him, and it may have an adrenal involvement due to a disseminated tuberculosis, which would have led to a hypoglycemia in this patient.
Very good. I think it's very important. When you told there is no pigmentation, I was thinking that you are thinking that there is no evidence of adrenal insufficiency. In this patient who has got probable tuberculosis, adrenal involvement is quite common, and they can go in for hypoglycemia. Probably in this patient, it is because of nutritional deficiencies. But we also know that in a patient with immunodeficiency, they can also have other diseases like histoplasmosis, which can involve adrenal as well as the lung, and everything can be explained with that also. And I think this is okay. And anything more, Jayanti, Dr. Usha, anything more to be discussed on this?
No, I think you have done a great job. Thank you for taking him through analysis of the examination findings. So Dr. Philip has already highlighted the key components, that how to look for features of obstruction on abdominal examination, where the distension is it central or peripheral, and any particular site which is involved. So in this particular patient, it is periumbilical, and you can see that the flanks are all empty. So it is more like a small bowel obstruction. And I think what Dr. Naveen was trying to highlight on the fullness in the periumbilical area in a completely emaciated patient with a BMI of 11, that fullness may indicate that there is clumped bowel loops at that particular site. And this patient obviously has frank features of malabsorption everywhere. And his systemic examination is not contributory, except for the fact that the lung has crepitations on the left side, and the patient also has limited power due to nutritional issues, but there was no features of any neuropathy on clinical evaluation. However, we don't have an electrical study and neural stimulation study to assess that.
Usha, can I stop here and ask a question to Naveen?
Sure.
See, it's good that you brought in this cardiovascular examination. In this patient with the diarrhea, suppose the patient, what is the relevance of examining the heart? Naveen.
One is, sir, for cardiac examination, I would like to look for any involvement of the tubercular disease per se. Patient may have a pericardial effusion, where I can make out the patient might have a decrease intensity of the heart sounds will be decreased, or the cardiac borders will be enlarged. Either in case of a vitamin deficiency, this patient may have a thiamine deficiency. Thiamine deficiency again leads to a cardiomyopathy in these patients.
Okay. Other than that, suppose it's a neuroendocrine tumor of the intestine, any cardiac manifestation?
And sir, in carcinoid syndromes, patient may have a features of tricuspid and pulmonary regurgitation.
Because now this patient has got chronic diarrhea, and but there is no flushing attacks and all. But it should be in your mind that the patient has a diarrhea, cutaneous manifestations, and patient, you should always examine. And even if you say, you should say that there is no cardiovascular or valvular involvement. I think that is very important in mentioning that. And lung examination is also very important in this patient. What type of lung involvement? Because if it is empyema, if it is cavity and all, makes a lot of difference for us rather than just some findings. And in this era of COVID, lung involvement, always we make sure that we are not having an added COVID infection, as Dr. Jayanti has told. Thank you.
Yeah, very important points Dr. Matthew has brought out, that systemic examination and general physical examination give you a lot of clues to what is the diagnosis of chronic diarrhea in a patient. So CNS examination, especially for neuropathy, for cerebellar ataxia, and as well as the general mental status of the patient, all these things can be important. In Whipple's disease, you can have CNS involvement. And we had cardiovascular involvement, which was highlighted by Dr. Matthew, that you can have carcinoid syndrome affecting the right side of the heart. You can have tricuspid regurgitation. You can have pericardial involvement, and you can have also a cardiomyopathy due to nutritional issues. So these things should be looked for carefully in these patients. And lung involvement is very common in patients with various forms of GI involvement due to various diseases. So careful evaluation and documentation of the lung involvement is necessary. So with this, the clinical diagnosis rests at chronic painful small bowel diarrhea with partial small bowel obstruction with evidence of malabsorption, severe malnutrition, anemia, left-sided pleural effusion, and features of a previous ICTD placed in the left side. And clinically right now, the patient is also having patient is presently emaciated. During the hospital stay, he has developed fresh fever and increased respiratory rate and cough. And on examination, he has increased crepes on the left side. So this is what has happened in the last 2 days in this patient. With this, the differential diagnosis rests on lung involvement and gut involvement. First, possibility of disseminated tuberculosis, and second, of Crohn's disease. Thirdly, I would add to this that there could be an underlying immunodeficiency which needs to be worked up. So Dr. Devendra Desai, can you take on the investigations from this point? And Dr. Daya, you will present the investigations and discuss the investigations. Dr. Devendra, please.
So we had a very good discussion about history, examination, and just a couple of things that I would like to say. That the good thing that Dr. Naveen has mentioned, that he has taken consent of the patient before taking the pictures. And this is useful when you are going to watch. One of the rare cases that you are going to write in the journal, they will ask for patient consent always. So that's a good thing. Other thing I wanted to mention about examination, you mentioned BMI of 11.5, but you should mention with that you have corrected it for edema fit. Okay. So now let's move on to, so Dr. Dayal, what investigations do you want?
First, initially, I would like to see the hemogram of the patient.
Yes. So I just want to interrupt you for a brief. Now this patient is admitted in the hospital. He has been investigated. So you would say that, okay, I would like to review the investigations which have already been done, because this is a sick patient and we don't want to submit him to extra investigation when you can have something from the already done investigation. So let's go on to those. So from the differential diagnosis, what investigations do you want? So Dr. Usha Datta very nicely summarized the diagnostic order. Okay, and now what would you like to have?
So firstly, I would like to see the features evaluation suggestive of any malabsorption, or like in the form of anemia.
Very
if
good.
There is any what type of anemia is there? Then if there is any thrombocytosis, which might suggest a inflammatory bowel disease.
Yes.
Then I would like to see in LFTs albumin level, then AG reversal if it is because of immunodeficiency. Then I would like to see if there is any triglycerides malabsorption, lipid profile. Then if there is any coagulopathy to suggest vitamin K malabsorption. So
okay, so you would first want to characterize anemia. So let's do that. So in this patient, you have the investigations in May and August. So what do you think?
So the anemia in this patient in May appears to be normocytic, normochromic. Although we don't have peripheral blood smear, it could be by this thing. So, and there is thrombocytopenia from the onset of disease, and the thrombocytopenia is persistent. And although there was neutrophilic leukocytosis in May, which is improved, but the anemia remains to be normocytic.
Okay,
could
fine.
be because of.
So now let's move on. Agreed. So there is anemia, and it may be either normocytic or it could be dimorphic. Right?
Yes, sir.
So in absence of peripheral picture, we cannot comment further on this. let's move on to what do you want next?
I would like to see the LFT.
Okay, let's see.
Profile.
Okay, let's see the next slide. Yes, you have the LFT, and you tell us what is the salient feature.
Sir, in LFT, the albumin is significantly decreased, suggestive of it could be because of inflammation or it could be because of decreased absorption. Second, there is coagulopathy, 2.18. So it could suggest vitamin K malabsorption.
Right.
Then in lipid profile, the total cholesterol levels are very low. Triglycerides level are very low. So it's long-standing malnutrition, which is severe.
So it is significant malabsorption, severe malabsorption.
Yes.
Yes. On the left side.
In CRP, the reports available here, the CRP is suggestive. In July, it was 208. Suggestive of acute inflammatory state, does not contribute to diagnosis. Then we would like to see the calcium.
No, CRP level. Does contribute to diagnosis, isn't it? We know that it is high.
We just know that it is inflammatory. It will not help in the DDs we've kept.
Okay, no problem. We'll come to it later, little later.
It would help that there is evidence of significant inflammation.
Yes.
So it substantiates your diagnosis of TB or Crohn's, and otherwise other mucosal diseases like, where the inflammation is not a dominant component like celiac disease or other things will not have elevated CRP.
Exactly.
Okay,
so we don't get so high in the malabsorption disorder.
Devendra, can I make a point?
Yes, please.
No, at this point, won't you tell that to do a stool examination for this patient along with this one?
Yes.
That's also quite important. No?
So we complete this and then we go on to that.
And one other point here on the investigation, you can see that the serum sodium is low.
Yes.
And we were suspecting Addison's disease with low glucose. So this is important. You expect the potassium to be high in these patients with Addison's disease. But you have to remember that this patient is having a chronic diarrhea and a wasted kind of a situation. In these situations, the total body potassium is very low. So you may not have elevation of serum potassium due to Addison's in patients with chronic diarrhea and total emaciation. And also notice that the serum creatinine is very low, indicating very limited muscle mass.
Yes. And with higher urea.
And higher urea.
Yes.
And the total cholesterol is extremely low. This is the lowest cholesterol I have seen in my life of any patient, 26. So this is highly incompatible in that situation. That is why this patient needs rapidly nourishing him by taking care that he gets a TPN and also looking for refeeding syndrome, because in that situation, all these electrolytes may get significantly altered.
Yes. So,
and here you have to also comment on the globulins, because globulins is important indicator of the B cell function. Yes, Dr. Devinder.
Sorry. So here, what do you think about globulin as Professor Usha Datta pointed out?
AG reversal.
But the globulins are probably on the normal side.
Normal side.
Right. So
now,
that.
Now, Dr. Usha, at this point, we have got a very low lipid profile. Don't we think, should we not think about beta lipoproteinemia or all these things, the DDs at this point?
Yeah, we could consider that. We could also consider that the patient may have intestinal lymphangiectasia and may be losing fat through the gut. So combination of this, A-beta lipoproteinemia can also be considered. This patient doesn't have any various other neurological manifestation, but definitely is a possibility.
Okay, now, yes, as Dr. Matthew pointed out, the next relevant investigation would be stool, and your comments, please.
In stool, there are no pus cells or no RBCs, no cyst, ova, atypical organisms, which is seen. So there is no feature suggestive of, there are no WBCs to suggest that it is an inflammatory this thing, or there is no overlapping diagnosis of, there are no two diseases contributing to the original pathology. So there is no.
Okay, what would.
If there is a.
Fair enough. So
here I have two caveats to mention. One is we do not say inflammatory or non-inflammatory just by looking at the pus cells or RBCs, because the sensitivity will be very poor in a patient with chronic diarrhea. We use calprotectin to say whether it's inflammatory or non-inflammatory.
exactly.
And the second caveat here I wanted to mention here is that the ovoparasite cyst, again, the sensitivity is very low. And nowadays we have PCR for giardia, antigen for giardia. These things should be tested before we say that this patient does not have giardiasis, because if there is immunodeficiency, giardiasis is a very important possibility. Just a routine microscopy does not exclude giardia. Yes, Dr. Devinder.
Yes, completely agree. What Dr. Usha said, that okay, if you have a high suspicion of inflammation, then you would do something like stool biofire, but it's very expensive, and in the given situation it is not necessary. Calprotectin is one other test. Let's see whether we have the calprotectin report, otherwise we go to the next investigation. Let's have the next.
It's awaited. Tomorrow it would be ready.
Fair enough. Okay, because they do it once in a week also, so all the investigation may not be available in a given case, right?
Yes, pleural fluid.
Pleural fluid, excessive of neutrophil predominant, and we have to rule out empyema, so we have to see the glucose levels.
Yes, very good. Yeah,
and the pH of the pleural fluid.
Yes, we do need that. In this patient, we don't have it right now. But would you comment on ADA of 3 in pleural fluid?
ADA is very low. It is not contributing to the diagnosis of TB, but it could be.
Yeah, so the caveat for all the residents to understand is that ADA can be falsely low in a patient who's so severely malnourished that he is not able to mount an immune response. So in such a situation, just like how we don't look at MON2 in a patient who's severely malnourished, here ADA may also be falsely low. So a low ADA does not exclude a possibility of a tuberculosis. Okay, so here in this patient, we have the cortisol levels. The 8 AM cortisol was elevated. Sputum AFB was negative, and there was no features to suggest CGD. IgG levels were elevated, was the high normal range, and HIV, HbSAg, and anti-HCV was negative.
This is one of the most important informative slides of what diagnosis we had thought, and we know that at least we don't have the NBT normal, IgG normal, and HIV normal. So your comments?
Yes, sir. We were suspecting underlying immune deficiency with overlapping tuberculosis.
Correct.
So since HIV is negative,
yes,
that we can rule out. And sputum AFB is also negative.
Now that brings us to the actual relevant investigation. So what would you like to have next?
I would like to get a CT scan of the chest with
abdomen and chest, because there was some doubt about perforation and ascites. So we would have let us review the imaging that was done.
Okay, ultrasound is largely not contributory, so we go to the abdominal X-ray. In any patient with intestinal obstruction, abdominal X-ray is essential before you go to CT scan, because it tells you the level of obstruction and there can be ancillary findings which you may find. So abdominal X-ray, erect and supine, with a minimum gap of 2 to 5 minutes between both the X-rays, so that the air and fluid will redistribute itself. So Dr. Naveen, please interpret the radiological findings of this patient.
The abdominal X-ray, the erect abdominal X-ray shows a rhylostobe in situ with a gastric bubble. I could see some of the prominent small bowel loops on the periumbilical region and the left. In the periumbilical region and also on the right side involving the right lumbar region. There is some prominence of small bowel loops.
So there are just some few bowel loops which are in the periumbilical area, which on clinical examination was also palpable as vague abdominal lump. and you can see a nasogastric tube in place. And what can you see on the X-ray?
An X-ray on the CP angles are clear, and in the upper lobe of lung there is an area of consolidation patch, and also there are small cavitatory lesions could also be seen in the upper and mid lobe.
So there is evidence of cavitatory lesion and infiltrates in the lung.
Dr. Usha,
So,
I think,
yes,
a very good message or a lesson you have taught is that you always do a plain X-ray abdomen. We should do an abdominal X-ray. It's easy and very easy to find out. So I think it's very relevant that we should go for a supine and direct X-ray abdomen before going for CT. I think it's very important.
Yes. Yes, interpret the chest X-ray, CT findings.
The CT cut section in the mid-axillary window is showing a area of a consolidation in the left upper lobe of the X-ray beam, and in the available cut section, I could not make out any lymph node enlargement. And
this small areas of breakdown also.
This is a parenchymal window showing an area of consolidation in the left upper lobe with cavitatory lesions. And we can see one area of one cavitatory lesion in the left upper lobe with an air fluid level. You can see in this. And this is the abdominal CT with the oral and IV contrast in coronal sections, where you can see that contrast has been not gone through the distal small bowel loops, where you can see the bowel loops have been clumped in the left hypochondrium, middle and lower part of the abdomen. There's the clumped bowel loops, and the small bowel loops are also dilated.
So, yes, so this
suggesting
CT
the
shows
level of,
that the, yeah, go ahead, Dr. Devendra.
So what do you think now based on this, the level of obstruction is?
Sir, based on this, I think the level of obstruction, either it may be in the distal jejunum or the proximal ileum part, sir.
So distal.
Yeah, so it's like a mid-gut obstruction, and for all the residents who are attending, you can see that the jejunal loops are all clumped up in the left upper quadrant, and you can see that the contrast is not going into the distal small bowel, and you can have the small bowel feces sign, you can have air, and it looks, this is actually a small bowel, but it is looking as if it's a large bowel. So this is also a feature of any obstruction, and you can see that there is thickening of the peritoneum here around it. So all of this suggesting that there could be a localized collection or a cocoon which is getting formed at this place. Yes, Dr. Devendra, do you want to add anything to that?
No, perfect. No problem.
Okay, so here again, you can see that there is this thickening which is coming up. Yes, Naveen, do you want to describe it quickly?
In this, you can see the in the lower section, axial cuts, the bowel loops have been clumped and they has covered by an outer membrane. That suggests of a cocoon in this patient.
Yes.
And now, if you can see this, you can see that there is a bulge in the abdomen, and wall. That is what we felt it. Yes.
Yeah, so this is a very important point Dr. Desai has made, that whenever you do a clinical examination, after that, see the radiology and see what is your clinico-radiological correlation. So that will help you improve your own clinical abdominal examination findings. So this was a bulge that we were feeling in this particular patient. And yes, so again, these are cuts which you can see these. And you can see that these will not be palpable clinically because this is in the pelvic floor per se. And one more cut I wanted to show you here, the one in which there was a scaphoid abdomen. Do we have that? Okay, so there is not much of any ascites right now. That ascites has disappeared. And now we are left with just a cocoon there with evidence of midgut obstruction. Yes, now we have the poll question here.
All of the following conditions can be associated with abdominal cocoon except peritoneal dialysis, bacterial peritonitis, malignancy, and celiac disease.
I can see that about 162 people are answering the questions.
93% said it's celiac. You will not see cocoon in patient of abdominal celiac disease patient.
So this is absolutely right that any situation where you get a cocoon, there has to be a peritoneal involvement. Celiac disease is not a feature. And Dr. Anurag Jaina has put up this slide. Yes, Anurag.
The causes of abdominal cocoon are mostly primary, idiopathic, or secondary. In secondary, the causes are mostly peritoneal dialysis, tuberculosis, malignancy, ruptured tumors like GIST, in renal transplant patient, post-operative condition, drugs like beta blockers and ergot, and generalized peritonitis like bacteria, eosinophilic or meconium. The next poll question: which of the following sign is associated with abdominal cocoon? Comb sign, bird beak sign, cauliflower sign, and water lily sign. Can we please run the poll?
Yogita, can you please run the poll? Yogita, can you please run the poll? Dr. Desai, am I audible?
Yes, yes, you are audible.
Yeah,
yes.
I think Devita has not yet got onto the poll. Anyway, this you can just answer. Yeah, it has come on.
She must have thought it is a difficult question.
Almost 89% people answered it right. It's the cauliflower sign.
You have written water lily and watermelon on the other side. One side it is water lily, other side is watermelon. Anyway, it is not, that is not the answer. Cauliflower sign is the answer. I think, you know, in this context, I think Dr. Usha,
yes.
when you see a bulge like that, I was about to ask that when you see a bulge there, that if it is persistent, you may have to think about that this could be a cocoon. Otherwise, you know, if it is a bowel which is obstructed, if after vomiting, if it reduces significantly, then probably it's actually a bowel which is accumulated, because it's very difficult to diagnose a cocoon clinically. It's mostly a
yes, yes. Yeah, I agree. The cocoon is typically a CT-based diagnosis, but clinically sometimes you can get an indication, especially this patient was emaciated with hardly any abdominal muscle to speak of. And that is why we could feel this vague lump in this patient. Otherwise, normally you may not find. In a patient with cocoon, you may just find resistance to palpation because the bowel loop is under the peritoneal thickening. So you may not palpate these free bowel loops in these patients. I agree with you. So clinically, we can just say a set of matted bowel loops in these patients. Okay, so that is a typical cauliflower sign. And you can see all the bowel loops, instead of being free floating, are all, you know, matted up together. The last poll question.
What is the percentage positivity of gene expert in tubercular ascites? Options are 5%, 18%, 47%, 90%. What percentage will show gene expert positivity in TB?
Here the guess will be right.
I think the house is divided. 42% answered it as 18%, and that is the correct answer. The gene expert positivity in patients with intestinal tuberculosis is only around 8%. In peritoneal TB, it is around 18 to 19%.
Yeah, so it is very important for us to understand that in tuberculosis, none of the tests have 100% sensitivity. So that is why we use a combination of clinical scenario with the investigations, and not also one investigation. We use multiple investigations to increase our sensitivity. So a single test negative does not rule out tuberculosis. So if gene expert is negative, it does not rule out tuberculosis because it is present in only about 18% of peritoneal tuberculosis. So quite often we should use a combination of tests in the conjunction with clinical scenario to make a diagnosis of tuberculosis in our country. So in this patient, interestingly, yesterday night the report has come. This patient could not expectorate. This patient was not fit for a BOWEL evaluation by the pulmonologist. So we had an NG aspirate in place. So we just sent the NG lavage fluid, and that has come as gene expert positive. So in the setting of cavitatory lesions in the lung, infiltrates in the lung, and an abdominal obstruction, small bowel obstruction, gene expert positive in the lavage fluid gave us a very simple diagnosis of tuberculosis, and there is no evidence of rifampicin resistance. And that is the reason, but we have to work him up in detail for immunodeficiency state, which could be contributing to his lack of response. He has also not been regularly taking ATT because of his repeated hospitalization and his intestinal obstruction, things getting stopped. So a message to the residents all over the country is that in patients with tuberculosis with intestinal obstruction, you can still continue anti-tubercular drug through the nasogastric aspirate in the presence of active obstruction and clamp the tube for about 30 minutes to ensure that the ATT gets into the system. Streptomycin, amikacin are injectable antibiotics which can be given IV. Levoflox can be given IV. There is also streptoarbazide, which is streptomycin with INH, which can be given IV. So it is very important in patients with obstruction that we continue ATT even during the period of obstruction, because that is the definitive drug we have in these patients. So here we have the utility of gastric lavage for diagnosis of tuberculosis in patients who are unable to expectorate. Dr. Anurag Jena, please.
In this study, it was 85 patients above 18 years of age, and they found gastric lavage smears were reported to be positive in 66% and culture in almost 85% from the gastric lavage aspirate fluid.
So this is an additional thing we can add to our armamentarium. So with this, the final diagnosis in this patient is disseminated tuberculosis, pulmonary in the form of lung lesions in the form of cavities, multiple cavities and infiltrates, peritoneal involvement, which is debatable whether it is directly due to peritoneal involvement or could be secondary to a sealed perforation. There is a secondary reaction of the peritoneum. Intestinal involvement in the form of small bowel tuberculosis affecting the midgut, abdominal cocoon, partial small bowel obstruction, a sealed off perforation, malabsorption, severe malnutrition, anemia, which is nutritional, as well as a combination of chronic diseases. And there is left pleural effusion. Patient may have had a left pleural effusion, which is now resolved completely. Possible adrenal insufficiency and immunodeficiency either due to nutrition or due to an underlying immunodeficiency state, which needs further workup. Thank you. With this, I would invite all the panelists to give their comments, and then we ask Dr. Govind to share his slides to complete the whole panel discussion. Yes, Dr. Devinder, can you start with giving us your views?
Very nice presentation, and what I liked about was the summary was very good. So your half the battle is won when you give a good history and summarize well. At the end of history, we should give the whether your diagnosis has changed after examination or no, and then give the relevant investigation that you would like to have. So then the discussion, you will have time to go to discussion. So this is my comment.
Yes, I just want to make like this. No, I think we should follow the basic principles of what we have taught during MBBS. You make a diagnosis from the history, support your diagnosis from the physical examination, supplement by the investigations. I think this is true. From the history itself, we have a disease which is multi-system. At least two systems are involved. There is GIT and lung. And the commonest disease that can occur is tuberculosis. And irrespective of tuberculosis response is inadequate, we again thought this could be a reason. And the additional investigation which actually gave us is the possibility of a cocoon. All other things could be, and even the cocoon could have been thought about when we have seen a persistent mass in the central abdomen, which is not relieved by vomiting or anything like that, then we could have thought about cocoon in that. But I think, clinical diagnosis of cocoon is not, I don't think that the examiners expect somebody to make during the clinical examination whether this is a cocoon. Cocoon is mostly a diagnosis by investigations. So I think this is a wonderful case and very good learning experience for me too. And this actually give the students a very important message also, is that I always keep the common diagnosis, the common disease in as a good possibility. Thank you so much.
Yeah, Dr. Jayanti and then Dr. Govind.
Thank you, Usha, for an interesting case. I think a few things that really need to be still discussed in this patient would be the diarrhea, the malabsorption, which is not yet being corrected, number one. And number two, the management of cocoon. The small bowel obstruction is going to be very problematic in this patient.
Yes.
So a very well discussed case and a lot of learning points. Thank you.
Yes, Dr. Govind.
Thank you, Dr. Usha and the team for a wonderful disposition of this case. I think it's a quite learning experience. Started with TB Crohn's and went towards abdominal cocoon, and that's a real life case. I'm sure all the people who joined today must have enjoyed this session, so nicely organized by team from PGI. And if I can share a small screen and so you summarize a couple of things which you like to remember as seeing a patient. How do you localize disease? I think a lot of things I'm going to do now will be repetition, but still for the sake of learning from it, let's do that. Dinesh, I'm unable to share screen again. Host.
Govind, I feel I should also attend the case presentations every Sunday so that
Sure.
My knowledge is brushed.
Please do that. Dinesh, I cannot share screen. I know what the problem is. Dinesh?
Till the time Dr. Govind fixes up the technical issue, there have been 3-4 questions. Govind, the first one is for you. In the previous case, how long was immunoglobulins should be given in a patient with CVID, the case which you presented last week?
So this immunoglobulin, since CVID is a lifelong disease, and therefore they will need immunoglobulin therapy almost lifelong, number one. Number two, the ideal duration is 3 to 4 weeks. You need to give immunoglobulin 3 to 4 weekly. But many of our patients do not, cannot afford this immunoglobulin 3 to 4 weeks. Therefore, we sometimes give 2 to 3 monthly, depending upon their resources. And many times we organize from different sources. And I think I'm happy to share there's a group of immunodeficiency in our country, and they can be reached through phone or through their web page. And they do help in organizing the free immunoglobulin to some of these patients. We have a pool of patients, almost 20, 25 patients with CVID following with us. And many of them get regular immunoglobulin through that resource.
Thank you. The next question was fever and cough with expectoration was also there in this patient. So there is a pulmonary tuberculosis also. So should we call it disseminated tuberculosis rather than abdominal tuberculosis? I entirely agree. And that is what we suggested at the end also. So in tuberculosis, it's very important to mention what all organs have been involved. So whether it is just the small bowel, is there peritoneal involvement, is there lymph nodal involvement, is there gut and lung involvement? So all these components should come in your final diagnosis. Then there is a question is, can we omit supine X-ray and only do an erect X-ray, because that alone can show us air fluid level. Erect X-ray has its own role in telling us air fluid level, but supine X-ray is the most important because it tells you the distribution of the bowel loops which are involved. So whether it is only small bowel or large bowel, the bowels can be characterized, whether it's small bowel or large bowel, jejunal or ileal or colonic on a supine X-ray. Air fluid level on an erect X-ray tells you only whether there are air fluid levels or not. So supine X-ray and erect X-ray both are required for diagnosis of patients with intestinal diseases.
Lateral decubitus is good, but the person cannot do the rest.
Yeah, lateral decubitus is useful in a subset of patients. Yes, lateral decubitus is also good in a patient who cannot stand up. And I find lateral decubitus is also useful in patients who have adhesive intestinal obstruction and the bowel loops are adhered to the anterior abdominal wall. Then you can see that the bowel loops are touching the anterior abdominal wall and there is evidence of something tethering it to the anterior abdominal wall.
Usha, I think, you know,
with this, Dr. Govind is ready to present his slides. So Dr. Govind, please. Dr. Philip, you wanted to say something before that?
I think, you know, supine exercise actually, it shows the anatomy better. And for example, in some cases where there are calculi are seen, no, it is better seen in supine rather than erect one.
Yes. Yeah, Dr. Govind, are we ready?
You're muted, Dr.
Govind. We can't hear you.
You're muted.
Dr. Govind?
Yes.
Yeah, we couldn't hear you. So can you start again?
So again, going to localization, how do we localize clinical signs? Last time we discussed about how to localize a mucosal disease, but looking at all others in GI tract. So we, in the whole GI tract, we divide into two groups of disorders. One is mucosal disease and other luminal disease. And all of these will lead to three important manifestations. One is because of mucosal disease or luminal disease, there could be loss of functions of the mucosa. Because of small intestine means absorption. So the diffusely involved that lead to mucosal absorptive defect. Luminal can lead to luminal obstruction. In the terms of it can lead to obstruction, and obstruction will not occur at one point of time. Obstruction will build up over a period of time, and at different stages will have a different kind of symptoms. And third one is if there are ulcers in GI tract, they can lead to bleeding. Bleeding can be occult or it can be overt. And also from the ulcers, patient can lose protein. So these will be, in summary, the manifestations of whatever disease we talk of, they will be ultimate outcome. So coming to, once we have a history and clinical findings done, then we divide that is it a predominantly mucosal disease, predominantly luminal disease, or a combination of both of them. And this is very important, which helps us in making a differential diagnosis. Also, we know that disease can be in the mucosa, submucosa, muscle layer, or even the serosa. And this patient we just discussed today had a more of what cocoon formation. It means the serosa was also inflamed for whatever reason, therefore led to adherence of bowel to each other and leading to matting of bowel loops, which is a common finding in many of these patients. So look at a kind of concept. In the small intestine, we're talking about mucosal disease. If mucosa is affected, which is diffuse all over and non-ulcerated. So this is one clinical situation. The second situation is mucosa is diffusely involved, but ulcerated. For example, for this is diffuse non-ulcerated celiac disease, tropical sprue, CVID. If you have diffuse ulcerations, you think of Crohn's disease, right? Then you have a patchy lesion, which are non-ulcerated, and you have patchy lesions in ulcerated in the GI tract. And what manifestation they will lead to? If they have a diffuse non-ulcerated, diffuse involvement, non-ulcerated, they will have an intestinal mucosal absorptive defect like malabsorption, which this patient had. You have a diffuse ulcerations that lead to absorptive defect. If large amount of mucosa is affected, they also will lead to bleeding and protein loss because of ulcerations. This protein loss may be visible, may not be visible. And you look at it in biochemical test that, okay, there's a low albumin and low globulin. So this is a pointer. If both albumin and globulin low, you think of protein losing state. If there's a disease which is patchy in nature, but non-ulcerated, then there may not be any clinical manifestations, right? Because mucosa is huge and there's a large amount of chemical reserve, therefore there may not be any effect. And this non-ulcerated part will not also have any manifestation. But whereas a patchy and ulcerated will lead to some absorptive defect, like if there's this patchy involvement of terminal ileum, it will lead to B12 deficiency. And if you're ulcerated, will lead to blood and protein loss. So this is how the basic concept of if you can go from here, these are the manifestations, we can translate this information into this disease or the other diseases. And based upon this disease, we'll classify which disease the patient has. Moving further, now going to second layer, I talked about mucosal layer. Now we're going to second layer. There could be disease in the submucosa, for example, lymphoma or amyloidosis or like disorders. Then if disease is localized, you will have a picture like mass lesion, which could be small or could be large, and symptom will be of more of obstructive feature. If it is a diffusely submucosal disease, then you have a thickening of mucosa and the patient will have abdominal pain. Coming to third layer, if it's a disease in the musculus propria, in the muscle layer, if it is localized, it's a mass lesion like leiomyomas, anywhere in the GI tract, lipomas. So they will be, so not lipoma will come submucosal, but leiomyomas, mass lesion. And if it's diffuse, then we know diffuse motility disorder of GI tract. All right. So now moving further, if it's a mucocerosa, then it could be matting of loops. Now coming to luminal disease. So and it's important to understand that in a luminal disease, if the mucosa is affected, they may not produce symptoms because there's enough lumen available. But as disease progresses over time, like become more and more compromised, the lumen gets obstructed and symptoms will come over time. The first symptom may be no symptom at all because there is still enough lumen left and therefore there's no obstruction to the passage of intestinal content. Then you have a stage of intestinal colic that if intermittently this gets blocked by food bolus or something, and that can lead to intermittent intestinal colic and patient gets better within hours. Third one is the symptom become more frequent. I think as this obstruction becomes more progressive, this becomes more obstructive. Then we have partial obstruction coming to complete obstruction. So this is how the symptom will progress. Please remember that patient may come at any point of time. Patient may come at this stage of time. Patient may come at this stage of time. So question is, at what lumen, if it is an intestinal lumen, at what size of lumen the symptom will start appearing? And this is again interesting thing that there are data from animal studies that if lumen get obstructed by 60%, then symptom of obstruction starts appearing, 60%. And that's true like mitral valve, 4 centimeter square mitral valve. If symptoms go less to 2 centimeter, the symptom of mitral valve stenosis starts appearing. And symptom, if is more than less than 1 centimeter, the symptoms are severe. So again, I said that they will have a different symptoms. What symptoms of obstruction? They will have first colic, but this colic may be associated with ball of wind formation, like a gola formation in the abdomen. They can have increased borborbi, gurgur ki awaaz. They can have blotting. They can have and one of the very important things which I really want to emphasize, that as patient, when the symptoms, what they want to do to get symptom relief when have these symptoms. And many patients will come that I want to vomit out or I want to pass stool, my symptom will get better. And this is an important point which tells you confirmed that this patient has an intestinal obstructive symptoms. No, may not be complete partial obstruction, but they are obstructive features. And if later they can have a partial intestinal obstruction. Furthermore, I can skip this. So again, we discussed about obstruction, proximal, distal we discussed, but only thing in last point, I want to highlight one important point that all of us use the term called subacute intestinal obstruction. To my mind, this is not an appropriate terminology. But most textbooks of gastroenterology or medicine will divide obstruction into either partial intestinal obstruction or complete intestinal obstruction. There's no term like subacute intestinal obstruction. Acute, subacute, and chronic are time factors. Acute, subacute, in our mind, we know them by time. We don't know by severity. If it's a subacute, we're talking in terms of severity. Therefore, we should not use this term. And once you publish a paper, never publish paper in the term of SAIO, because this will not be recognized in many things. Therefore, ideal term is a partial intestinal obstruction. I think with this, I'll stop this discussion here now, and I'd like to thank everyone for participation in this meeting. I want to thank all the teacher faculties like Dr. Usha Datta did a wonderful job. Dr. Jayanti, Dr. Devendra Desai, and Dr. Matthew Philip. This was a wonderful case discussion. Wonderful, the questions for the poll for audience. Thank you, Dr. Anurag, for beautiful questions you defined, and each one of them carried a carry-home message. Thank you so very much for this joining in for this program, and we invite you to participate into yet another program next week, same time, 11:30, on a different case. This time we'll discuss a patient with an abdominal lump, and how do you approach how do you analyze, how do you approach a patient who has lump abdomen, and which are very important in clinical gastroenterology. With this, I want to thank everyone. And also I want you to, we'll send a feedback form. As you are aware that this kind of the clinical case discussion, we have never done in group. We always do in a small group in our hospitals. And also we do gym program where there's a face-to-face. But here, 6 of us this side, and we have 200 people on the other side. How do we connect with each other? Therefore, I want your feedback. Last time you sent feedback to us, and we tried to modify some of this. We want to further improvise to make this session much better in time. And therefore, I request that all of you please do send feedback to us. Ms. Yogita will send a feedback form to all of you, and please do get back to us on that. Dr. Usai was saying something. Yeah, unmute please yourself. It's okay to unmute yourself.
Yeah, can you hear me?
Yes.
Yeah, there are 2 questions from the audience. I just wanted, because they have sent the questions, we should answer them. One question is duration of antitubercular therapy in patients with intestinal tuberculosis. If there is no resistance suspected, then it's 4 drugs for 2 months, followed by HRE, that is 3 drugs, INH, rifampicin, and ethambutol for another 4 months. That is the standard regime. We can extend it to 9 months in case it is required in particular cases. Otherwise, the recommended one is for 6 months. The other question is, what was the duration of obstipation? Now, in a setting of a patient who has abdominal pain and the obstipation is troublesome to the patient, then it starts becoming significant. I don't think there's any textbook definition for duration of obstipation. However, I'll look into it before we can give a definitive answer. Yeah, thank you, Dr. Govind, for organizing such a wonderful session for teaching postgraduates of our country. It's really laudable that ISG has started this venture for teaching postgraduates, and wonderful slides which you presented at the end. Thank you so much.
Thank you, everyone. And we'd like to see you next week at 11:30. Till then, have a great day ahead.
Bye-bye.
Thank you so much.
Okay, bye-bye. Thank you, Dr. Philip, Dr. Desai, and Dr. Jayanti. Wonderful. And I should thank Dr. Anurag Jena and our 3 residents who have participated, Dr. Jayendra, Dr. Naveen, and Dr. Daya. Thank you.
They have done extremely well. Very good.
Thank you. That adds to their confidence. Thank you.
Thank you, Dineshji. Thank you, Yogita, for organizing this meeting. Thank you so much. Bye-bye.